So I'm going to talk today about really a program of research that started some 15 years ago. At that time, I was at McMaster University in Hamilton, and really sort of started to think about best ways of implementing sort of a population-based approach to reduce the burden of cardiovascular disease. And as with most of those programs, over the years you accumulate a lot of partners. So these are some of the partners that we have accumulated over the years. In fact, the program has been implemented in Ontario, in Alberta, in British Columbia, and now we are in the process of implementing the program in Quebec. The problem is really not unique to Quebec or to Canada. It's really a major issue facing both developed and developing countries. We are really facing widespread and growing epidemics of obesity, hypertension, diabetes, heart disease, and stroke. And of course, this is all happening in the context of aging population. So, at one time we sort of dreamed that people would live very healthy lives for a very long time, and then they would rapidly deteriorate and die. And that would be sort of the optimal outcome of the modern healthcare system. Of course, that hasn't happened, and in fact, more and more people do in fact live longer, but they also live longer with significant morbidities, with poor quality of life, with low participation in the labor force. So our system and other systems are really facing this challenge of how do we deal with some of those issues, and again, in the context of fewer resources allocated to healthcare system. Again, Quebec is not unique. Over 50% of our budget is now dedicated to healthcare services, and that has really very important implications in terms of how much money we can spend on education, on infrastructure, on other things which are important in the society. Again, a striking thing is that a lot of those diseases, which are resulting mainly from sort of a different lifestyle, we tend to be much less physically active. We tend to have much poorer diet. All those things are ultimately responsible for very significant morbidity and mortality, not just in terms of cardiovascular disease, but really in terms of many chronic diseases. They have a very common root, which are 5 or 6 modifiable risk factors, which are ultimately responsible for those conditions. So when we sort of start thinking about it, in terms of what could we do, we had sort of some guiding principles in terms of what we were planning to accomplish. So one issue was really about shifting the distribution of risk at the population level. And that's, of course, always very challenging. But we also know that if we can shift the distribution of risk at the population level, the impact on the overall health of the population is going to be much greater. Our system tends to be very good and very focused on high-risk individuals. But in terms of absolute numbers, there are many more people at moderate risk who would ultimately develop the disease and suffer the consequences of those conditions. So the populational approach has the advantage of actually having a much greater impact than the system that focuses on very high-risk individuals. Having said that, I think that both approaches have merits. So we're really looking at how can we combine sort of the individual sort of high-risk approach with the populational approach. I think that another issue, and this is again something which is very prevalent, not just in Quebec, in Canada, but I guess in most developed countries, is that we tend to have a system that's very poorly integrated and coordinated. So we have a multitude of programs, of resources in most communities, and a lot of times they are very poorly integrated and coordinated. So they are underused, they are used by the wrong types of individuals, they are not necessarily connected in a proper way with primary, secondary, tertiary level of care. And the result is that we're spending a lot of resources, a lot of energy, and ultimately we don't really have huge impact in terms of how those resources are being allocated. Another thing that was of considerable interest to us was that there are a lot of programs which are what I would call Rolls-Royce programs. So under perfect conditions, with unlimited resources, we can do wonderful things. The problem, of course, is that most of those programs are not scalable. We cannot really implement or scale them up because our system doesn't have enough resources to make it happen. So the idea was really looking at things which are relatively inexpensive, quick and easy to implement, really in any community, as opposed to focusing on something which is sort of very effective, but not likely to be ever implementable on a larger scale. We also know that a lot of programs that have been attempted in the past in terms of community programs tended to have problems in terms of very poor or selective uptake of people who would participate. And almost inevitably, very poor connection with appropriate follow-up. So people with very good intentions would, for example, organize screening sessions in the shopping malls or those kinds of places. And the problem almost inevitably is that, yes, you identify a lot of people at risk, but you don't really provide a meaningful follow-up. You don't link those people back to the healthcare system. So we were sort of trying to address that issue as well. And then, because of course we are academics, we are really interested in having something that's very rigorously evaluated. So again, if you recall, in the 1970s, in the 1980s, there was a lot of excitement about sort of population strategies. And some of them initially showed some interesting results, but then people started to look a little bit more closely at evaluation. And a lot of times there were issues of using very soft outcomes, not having a proper control group, not really taking into account the temporal changes that might have been responsible for those changes. And I think that the sort of excitement about the population sort of level studies have really died down quite a bit since the 1970s and 1980s. And we felt that one of the reasons was that if we're going to put a program like this, let's make sure that it's really evaluated, utilizing hard outcomes, utilizing sort of proper randomization with sort of the best that we can do in terms of evaluation. So you probably sort of have seen this graph before. This is this notion of what you can accomplish by reducing the level, in this case, of blood pressure by actually very small amounts, but if you do it at the population level. And you can see that the reductions in terms of stroke, congestive heart disease, and the overall mortality are really incredibly impressive for actually fairly minute changes in terms of blood pressure, but this is blood pressure at the population level. So you're not focusing on the high-risk individuals. You're really trying to sort of reduce the blood pressure for the full population by 2 millimeters, 4 millimeters. So as I mentioned before, the guiding principles really also had to do with developing something that's effective, sustainable, and potentially scalable. And this is because we felt that an effective program is much more likely to be sustained, and a sustainable program is much more likely to be scaled up. So that's really sort of the reason why we sort of started simple and really looked at things that we felt could potentially be of use. So the early days, I mentioned I was at McMaster at that time. It was really a group of 4 or 5 of us meeting weekly and sort of brainstorming in terms of what we know, what are some of the challenges, what are some of the strategies that we could potentially put forward. And of course, over time, our team got much larger. And we sort of started fairly small in terms of developing some proof of concept studies. We started initially with one family practice, so a family practice in Dundas, which is a small town just outside of Hamilton, so roughly 2,000 patients. We only invited elderly patients to participate. We've done sort of a similar program just with one pharmacy. So the idea was really to start sort of building a little bit of a knowledge base in terms of what works, what doesn't, and slowly sort of developing different aspects of the program. One of the sort of things that we were always sort of very keen on is that pharmacies in Canada tend to be largely underutilized, although that has sort of changed quite a bit over the last few years. The scope of practice for many pharmacists is much larger than it used to be. Pharmacies have the advantage of a lot of them being open 24/7, a lot of them having easy access, frequently free parking, and of course the added bonus of having a highly trained health professional that's usually not utilized to his or her full potential. And of course at that time, and even today, a lot of pharmacies had blood pressure measuring devices. So we felt that maybe this is sort of a good starting point. It was quite sort of interesting because as we started to explore that a little bit more, we realized that there were all kinds of issues with the validity and quality of the blood pressure devices that existed at that time in the local pharmacies. And almost as a result of that, I sort of developed a sideline of research and became an expert in blood pressure measurements. So we probably conducted additional 6 or 7 studies just looking at what's the optimal way of measuring blood pressure. But the starting point was that we had those pharmacies. They were taking a lot of blood pressure measurements. They were easily accessible to patients, yet there was very little that was really utilized for practical clinical purposes in terms of how those readings could be utilized in clinical practice. So as I mentioned, we sort of did a proof of concept with one family practice, and really we were looking at that stage, if we build it, will they come? If we start running sessions in the local pharmacies, would patients show up? We did compare sort of 2 different strategies of bringing people in, inviting them by mail, inviting them by phone calls. We conducted sort of a mini economic analysis to see which one was more cost effective, and it was decided that the mail approach was much more implementable and cheaper in the long run rather than inviting people by phone calls. As I mentioned, we also sort of tried to see if we could have a program that's strictly pharmacy based, so we ran a pilot project in one pharmacy in Ottawa. Then we sort of moved on, and we thought that we were sort of ready for the prime time and conducted a fairly large cluster RCT involving 28 family practices in Hamilton and in Ottawa. Despite the fact that we had very good response from the patients, approximately 40% of patients 65 plus who were invited presented to the sessions. We actually didn't demonstrate that we were able to decrease the blood pressure of those individuals. So we decided sort of to go back to the drawing board and sort of figure out, well, what do we need to change? How do we need to reassess our program? And we decided that perhaps we should have more of a community-wide approach, and we decided to concentrate on 2 communities of around 25,000 individuals, so Grimsby and Brockville in Ontario, both around 25,000 individuals, and again focusing on patients 65 plus. Along the way, we sort of started to learn more about how to mobilize the community, how to get family physicians and pharmacists involved. And we really sort of started to rely very heavily on involvement of volunteers as part of our approach. We also conducted a demonstration project in a community of around 20,000 in Alberta. And again, the idea was sort of to slowly prepare ourselves for what we felt would be a very sort of robust program that we were ready to sort of properly evaluate and see, yes, is this effective? Yes, is this implementable? And this is what sort of took us to a 39 community cluster RCT. So those were communities of between 10 and 60,000 in Ontario. And in fact, there are only 41 communities of that size in Ontario. And since we've done some pilot work in 2 of them, we excluded those 2, and we were left with 39. So basically all the communities of between 10 and 60,000 in Ontario were involved in the program. The intervention itself, so I haven't talk to you about what the intervention is. Now I'm going to spell it out for you. So it's really a community-wide promotion of what we call CHAP sessions, and we really utilize sort of 3 different strategies to bring people in to participate. So personalized letters from family physicians inviting people 65 plus to participate in those sessions, referrals from family physicians and from pharmacists for elderly patients to participate. And we also got quite involved with local media, with local newspapers, radio shows, TV shows, and really sort of posters, and really sort of promoting the program. We decided to rely quite heavily on trained peer volunteers, and again, this is partially because of the cost, partially because of the ownership. If you have locally trained individuals developing the program, there is much more ownership around the program. And also there is fairly strong evidence suggesting that interventions which are delivered by peers tend to be much more effective, especially around lifestyle issues. And again, the focus was very much on modifiable risk factors, blood pressure, and we felt that age-matched volunteers would be much more effective in terms of convincing elderly individuals to revisit their lifestyles in terms of diet, physical activity, and so forth. We also utilized automated devices to measure blood pressure, so we spend a lot of time working and validating BP True. The advantage of this device is that it's fully automated. It takes 6 blood pressure measurements at 1-minute interval, discards the first one, and averages the remaining 5. And the end result is that you have a much more valid and accurate measurement of blood pressure than what's normally done in the offices of family physicians, by nurses, or anybody else. It's sort of halfway between 24-hour ambulatory blood pressure measurement and sort of the routine clinical blood pressure measurement. So one of the selling points to family physicians as to why they would want to participate in the program is that we told them, look, we're going to provide you with a set of valid measures of blood pressure that you can subsequently utilize to diagnose or improve management of your patients. We also collected a variety of cardiovascular risk factors. Those were mainly self-reported. We asked people if they were physically active, if they were adhering to their therapies, if they had diet that included fruits and vegetables, if they consume a lot of salt, and so forth. But ultimately, it was a 1-page questionnaire, basically looking at a little bit of history and 20 cardiovascular risk factors. And then that information was shared with family physicians, with pharmacists, and with participants themselves. This was also an opportunity to provide educational materials and educational interventions to participants. So one of the things that we did, we actually created a list of all the locally available resources targeting specific modifiable risk factors. So if we identified someone who, for example, was not very physically active, but indicated an interest in becoming more physically active, the volunteers would provide that individual with a list of available resources, programs, and opportunities in their own community. Walking groups, gyms which are free of charge, and those kinds of things. And we also had community health centers and pharmacies that were available during those sessions to follow a specific protocol for those individuals who had very high blood pressure. So in this context, anyone whose blood pressure was higher than 180 would be reassessed by a nurse or reassessed by pharmacists, basically to confirm that in fact blood pressure was elevated, and to take proper history, reassess blood pressure, and connect with their family physicians if necessary. In some ways, really, the intervention itself is probably, a fairly close operationalization of the Wagner's chronic care model. If you look at different aspects, and what we did here, we sort of took the chronic care Wagner's model and we mapped on it really sort of the activities that we did as part of CHAP. And you can see that it is really about informing, empowering the participants. It is about sort of having prepared and proactive healthcare professionals, and it is really about activating the community and mobilizing different resources within the community. And the objective of the study itself was really to evaluate if the CHAP program can reduce stroke and CVD morbidity at the community level. And the primary outcome measure was really based on administrative databases. So advantage in Ontario is that there is something which is called ICES, which is a depository of all the administrative databases. And basically, we were working very closely with ICES to assess effectiveness of the trial. And really what we were looking at were admissions to hospital for acute MI, for congestive heart failure and stroke. That was our composite endpoint for the total population of residents age 65 and over. So basically, regardless of whether someone participated in the program, because this was sort of a cluster RCT, we looked at total population 65 plus in the control communities. We look at the total population 65 plus in the intervention communities, and we compare the admission rates to hospital for CVD in the control versus the intervention community. And it was a cluster RCT, and as I mentioned, the measurement of outcome is very objective. We really had no sort of involvement in that. It was really done through the population-based administrative databases. As I mentioned, the inclusion criteria was a community of between 10 to 60,000. They have to have at least 5 family physicians, at least 2 pharmacies, and really the only exclusion was that we didn't want to include in our denominators or numerators people who were institutionalized. So they had to be community dwelling people 65 plus, so they had sort of the opportunity to participate in those sessions. And as I mentioned, we excluded a couple of places where we've done pilot work, and we've excluded those which were really, strictly speaking, not communities. They were sort of, dispersed townships and so forth. And once we had sort of those 39 communities, we created 7 different strata based on size of the population 65 plus and geographic location. And then within that 7 strata, we have randomly allocated the communities either to control or to intervention. And in fact, the actual random allocation was done by an expert who was not affiliated with the study. So we really wanted sort of to be very clean that we had no involvement in selecting this community or that community. We just handed all the information to Alan Donner, who is someone who does a lot of work with cluster trials, and he conducted the random allocation for us. These are the actual sessions, so virtually all of them were held in the local pharmacies, and you can see volunteers and participants, sort of different pharmacies in Ontario. In order to assist communities with implementing the program, we actually prepared a fairly comprehensive implementation guide that provided a week-by-week activities that each community needed to go through in order to prepare itself for implementation of the program. And here, some of that pilot work and the demonstrations projects that we did at the community level were really quite critical, because basically we developed a lot of resources from really simple things like a press release. If you want to have local newspaper to provide coverage of the program, we would prepare a template where each community would just sort of put information that pertains specifically to their community, but the press release was sort of professionally prepared. Invitation letters that family physicians would send, posters that you could put in different places in the community, consent forms. So basically the implementation guide, and it continues to be a living document that's actually on our website, where we have sort of, as we sort of develop new tools, as we develop new things, we basically add that to our implementation guide. As I mentioned before, we did sort of create community profiles, basically looking at what's currently available and what is the risk burden in each of the communities. And then we have really created that comprehensive list of local resources because we felt that that would be a very important strategy in terms of providing participants with very sort of accurate information in terms of what's available. This is an example of an actual poster from the study. So you can see that in Stratford, which was in the intervention arm of the study, there was a total of 8 pharmacies, and each of those pharmacies would run during a 10-week period. So the program lasted for 10 weeks. During that 10-week period, each of them would run a session between 9 o'clock and 12 o'clock in the morning. And basically people could sort of attend any sessions that they wanted during that period through the letters that they received, posters, and so forth. As I mentioned, we haven't really collected tons of data because we felt that we would only collect information that's useful for the purposes of the program, since evaluation was in some way outsourced to the administrative databases. So we had sort of this one-pager in triplicate, which collected basically the key information with respect to risk factors around cardiovascular disease. And then family physicians would receive sort of a report. And what we did, we provided a list, 2 different lists to each family physician. One of them, people who were already diagnosed with hypertension, and they were rank ordered in terms of the highest systolic blood pressure. So the first person that the family physician would see is someone from their practice who is not known to be hypertensive, and that would be sort of and they would be rank ordered by their systolic blood pressure. We would also indicate when the measurement was taken. If there were multiple measurements, we would always use the last one available, and we would also indicate if they were diabetic or not, because the targets for blood pressure control are different for patients with diabetes. And then the second list included those who are known, diagnosed, and taking medication. Again, rank ordered by their systolic blood pressure. At 6 months, all family physicians received comparative feedback, basically comparing how patients from their practices are controlled relative to patients of other physicians in their community and other physicians in Ontario. So the idea was to create a little bit of a friendly competition. We know that audit and feedback tends to be quite effective. So the idea was that we would sort of give them some feedback. And we also provided them again with the list of the patients that we felt they should be looking after because their blood pressure was not optimally controlled. In terms of implementation, again, the 20 communities were randomly selected, and we were able to successfully implement the program in all 20 communities. We had 214 physicians that actively participated. Active participation meant that they have either provided us or sent personalized letters to their patients or actively distributed referrals during sort of opportunistic visits of their patients to the practices. So over 24,000 personalized letters were sent to patients 65 plus on behalf of family physicians, inviting them to participate. We had virtually every pharmacy that was available that took part in the program. It says here 129 out of 145. Really, the few that did not participate were because either they were not easily accessible, so some of them were in sort of very small buildings. They couldn't sort of accommodate that large number of individuals, but we had 90% of pharmacies that participated, which was really quite interesting. We ended up recruiting and training 577 volunteers. So across 20 communities, you're looking at around 30 volunteers per community. Of course, that would differ depending on how large was the community. The needs of a community of 10,000 in terms of volunteers is different than a community of 60,000. And during that 10-week period, we held 1,265 sessions. And we conducted over 27,000 assessments on almost 16,000 unique patients. So our estimate was that around 25% of patients 65 and plus participated in the program during that 10-week period. And then we sort of reported our results. So if you look at the baseline characteristics, on average, you're looking at just around 3,500 residents 65 plus in those communities, the average age. And this is, again, irrespective of participation. We are really looking at total population 65 plus in the intervention communities compared to the control communities. Having said that, if you can look at those numbers, our randomization was quite successful. None of those differences is of significant difference. So basically, it looks like our randomization worked quite well. If you look at sort of our primary endpoint, so our primary endpoint was admissions to hospital per 1,000 people 65 plus, and you can see sort of denominators for the composite. So the composite is admission to hospital for congestive heart failure, stroke, or MI, and this is comparison CHAP communities before the program, control communities before the program, and this is the rate after. And you can see that overall, we showed sort of a 9% decrease in admissions to hospital. We also had significant decrease for congestive heart failure and for MI, but surprisingly not for stroke. Again, one would expect that reduction in blood pressure would probably translate first and foremost for reduction in stroke. For some reason, that didn't happen. So I'll tell you about it a little bit later. Some of our secondary outcome rates, I think the first one is quite interesting because it shows a 14% reduction, although it's at 0.06 level, so not quite statistically significant, but we had a reduction in terms of the in-hospital mortality for cardiovascular conditions. And I think that this is interesting because it demonstrates that one of the mechanisms of the program was increased initiation of antihypertensive therapies in the intervention communities compared to control communities, and that was significant. So we had a 10% increase in the initiation of antihypertensive therapies. Then we also conducted economic analysis. Basically, you know, it's very nice to put a program in place. Is this program actually cost effective? I think here sort of the key message is that if you're looking at cardiovascular hospitalizations, and this is the cost in Canadian dollars per one resident 65 plus. So we have reduced the cost of around $40 per individual. Since there are around 70,000 individuals in each community, that translates into a reduction of around $2.8 million annually in terms of admissions for hospital. The cost of the intervention is around $20 per person. So basically, for each dollar that you put into the program, you're saving $2 in terms of hospital admissions. Now, if you were to extrapolate that reduction of 9%, and we sort of looked at, you know, if the program was implemented in Ontario, UK, or US, you would be looking at approximately 5,000, 30,000, and 120,000 fewer annual admissions if the program was fully implemented on that scale. And I guess what's interesting is that that kind of impact is really on par with fairly significant reductions in dietary salt, fairly significant reduction in terms of tobacco use, and fairly significant reduction in terms of obesity. Of course, there are, as always, limitations and new questions. So intervention was a little bit of a black box. There was a lot of stuff happening, so not really possible to tell which of those elements was ultimately responsible for the reduction. We also knew that by design, since we focus on communities of 10 to 60,000, that maybe this type of program is not really implementable in larger urban centers. And of course, again, we haven't dealt very much with different ethno-cultural minorities. Those smaller towns in Ontario tend to be fairly homogeneous in terms of ethnicity. We also didn't know what is the long-term effect of the program. And, can we actually implement a program like this on a wider scale and sustain it as an ongoing program? So we sort of started to play with that a little bit, developed a theoretical framework for those types of interventions, and really sort of started to look at, how can we start filling some of the knowledge gaps, really sort of to have a very solid knowledge base with respect to what needs to be done. So adaptation, evaluation of such a model in different settings. So currently we are working on implementing CHAP in Laval. And we are also working in the York region of Ontario, focusing on South Asian population to see if the program can be implemented there. We are also very much interested in fostering greater involvement of physicians, pharmacists, and public health professionals in the program. Almost finished a long-term sort of evaluation. We sort of looked at 5-year impact of the program to see what it does. And really looking at implementing and evaluating sort of different strategies to work with decision makers around scalability and sustainability of the program. I mentioned the CHAP Laval. Well, it's actually the last session took place last week. We worked with 2 groupes de médecins de famille. The reason for not doing a population approach is the fact that a lot of people in Quebec don't have a family physician. So we decided as a first adaptation to focus on people who already have a family physician, hence our work with Groupe de Médecins de Famille. We successfully recruited and trained 15 volunteers, half of them retired nurses. So one of the questions that people had was, well, it's all very nice to do a program like this in English Canada. There is a culture of volunteerism that doesn't exist in Quebec. So we proved them wrong. Yes, you can recruit and train volunteers in Quebec, and we only needed around 10 individuals. So in fact, we had probably way too many for what we needed, but we had 15. We also started to look at patients which are a little bit younger to see if we can invite people 40 plus. And in addition to doing blood pressure assessment, we also started to do assessment for pre-diabetes and diabetes, a questionnaire-based approach. It's called CAN-RISC, which is essentially a validated version of the FIN-RISC, which is a questionnaire-based risk assessment for diabetes. The latest device that we use also allows us to screen for atrial fibrillation. Because you have those multiple readings, you can tell if someone is missing a beat, and that device actually has fairly good sensitivity and specificity in terms of detecting people who are at risk for AFib. And we also measuring BMI and waist circumference, because those are important aspects of the CAN-RISC assessment. I had a nice video, but there is no sound, so I'm not going to show it to you. But we prepared sort of a nice video, really designed for recruitment of volunteers, but also recruitment of family physicians and pharmacists. We sort of describe sort of different aspects of the program. And that was just completed a couple of weeks ago. So it's sort of a brand new and very sort of polished, and it's in French. It's very nice. So as I mentioned, one of the things that we are working on is really sort of scaling up. So moving from here to moving there. So we would like to have something that tackles younger populations, that's applicable to urban and suburban settings, that tackles sort of the multicultural mosaic of Canada, that deals with the French-speaking population. And a lot of work now around use of new technologies. So we are in the process of developing data capture and data management that can be done on tablets, on cell phones. And of course, the dream is that ultimately we would like that information to be directly integrated into electronic medical records of family physicians, so they could have sort of the latest information on blood pressure and risk factors and those kinds of things. Just I guess, a couple of weeks ago, we are going global. So not surprisingly, because the program is so low cost, there was a lot of interest from places where there's not a lot of resources. And we had an ongoing relationship with a group in the Philippines. And we just received funding from CIHR for a 5-year team grant that would essentially look at implementing a program like this in one of the poorest areas of the Philippines in the south. The focus is going to be a little bit more on screening for diabetes, but we'll be also focusing on sort of broadly defined cardiometabolic disease. And the interesting aspect is that we have already created an international advisory committee. So we have people from Laos, from Tunisia, from Peru, that going to work with us very closely as we're developing and implementing the program in the Philippines. They would be our sounding board to see how do we need to change the program if we were to implement it in their settings. So I think that's going to be quite exciting. So to conclude, I sort of took you through that journey because I think it's interesting, at least for me, to sort of explain what are sort of the steps that you need to go through. A lot of times you sort of see the final product and you don't really understand where it started and, all the sort of baby steps that you had to take along the way, all the sort of challenges or the things that didn't work out. We had a couple of things where we thought that we were ready and we were not. So it can be done. I think that you need time, you need resources. I think that you need to have some vision in terms of where you want to go. It's clear that you have to work with people who bring different expertise to the table. I think that the idea of a single person developing a program or running a successful research is really a thing of the past, and different people do in fact bring a lot of value in terms of their knowledge, in terms of their expertise. It is also clear that it's not all about evidence, that there is a lot of pragmatism and opportunism involved in sort of developing your research program, and that it's really critical that you have a lot of partnerships and coalitions as you move forward. As I mentioned before, we sort of did publish quite a bit along the way, so we are all academics. So the big interest was that we sort of document what we have done, that we share the information with different individuals. So we had quite an impressive list of publications, and it's growing. So we have a few more sort of things in the works. We also did receive quite a few awards and distinctions for our work. Probably the one that's sort of most interesting is that CIHR CMAJ Top Canadian Achievement in Health Research. So we received that in 2013. Another thing that's sort of very nice is that both Canadian Task Force and US Task Force on Preventive Strategies, Task Force on Preventive Maneuvers, identified our program as sort of the one and only evidence supporting screening for hypertension. So if you go to Canadian guidelines, if you go to the American guidelines, essentially they recommend that screening of elderly population is recommended, and the only source that's being cited sort of to support that recommendation, which is a strong recommendation from both task forces, is the CHAP program. And as I mentioned before, we actually do have a very nice website, chapprogram.ca, where basically everything that we have developed up till now is available free of charge, no passwords, anyone can go and get it, and it's available in both French and English. And if you have more information, you can always get in touch with me. That's my email address. Thank you.
Merci beaucoup.